Okay, hello everybody. This is Seth Sinclair here. I want to thank you all for joining us. We are just 1 minute away from getting started. And so what I'm going to do is a quick kickoff of this session, and then we're going to get right into the deck. I'll introduce the panelists and the team, and then we'll move forward from there. So thank you again for all of you who joined us. We got a great response for this, especially considering that this is the first webinar in a series that we'd like to host moving forward with a focus on planning best practices for VA hospitals. We've got participants that signed up for this from around the country to include people that we've had the privilege of working with over the past years. And that includes some very experienced leaders and executives that chose to sign up for this. So we certainly appreciate that. I should also note that we do have several of our own team members on, and we probably won't do a bunch of individual introductions just to save time and be efficient, but it's great to have some of our staff on who's also very experienced as well. I mentioned before, this is our first webinar. This is going to be the first in a series. We've got more to come on other topics related to planning best practices. And I want to make clear to you guys that this was not intended to be a sales pitch. This is designed to create discussion around best practices that will help VA hospitals as well as all of VA overall in general. So while you might hear us refer to some of our solutions, that's not the primary focus of what we'd like to talk about here today. We're going to go for 1 hour. I will end this promptly at 1 p.m. Eastern. The format will be a discussion style session between myself and Tim, who I'm going to introduce here as our featured panelist in a moment. And I certainly would encourage anyone on here to ask questions. There's different ways you can do that. You can note through the chat that you'd like to submit a question, and I'll do my best to monitor that. And I can see here if anybody has raised their hand. And if I can't immediately respond to that, I will do my best to at least get to it before we end the session. If we can't cover everything in the agenda today, we may very well do a part 2. And there's a couple other topics in here while I mentioned where we will plan to drill deeper with future sessions. And last comment in terms of setup is we will plan to record this and be able to distribute it back out to anybody who's attended or registered. And for those of you guys who want to share this, you'll be able to do that by sending the recording. So with that said, let me just take a moment to talk about our goals for the session today. Having worked with dozens of VA hospitals over the past years, we've observed that trying to figure out how to best balance strategic planning and tactical planning and to make those fit together can be a significant challenge for VA leaders. And that applies to leaders at all levels, both at the corporate level, the regional level, and then certainly at that local medical center level. And the other thing we've observed is different sites handling this in completely different ways. And so it's not necessarily that that's bad, but there certainly are benefits to being more consistent in planning and how that can come together to, again, benefit the organization overall and its ability to achieve its highest level objectives in an integrated and measurable way. So for today, what we hope to talk through is some basic definitions on the levels of planning in VA, variables that affect planning practices and outcomes at those different levels. We want to talk about some specific best practices for achieving planning and alignment at each level. So again, we're talking about system-wide, regional, organizational, and then even down to the divisional level. We'd like to throw out some examples that we've worked with and observed over the past years. And then again, with time permitting at the end, open it up if anybody has any questions or specific challenges that they're facing that they'd like for us as a group to work with and brainstorm. So let me introduce our featured panelist again today, Tim Shea, who is the Chief Strategy Officer for Plan for Healthcare. Tim, thanks for being on, and would you mind just taking a few moments to talk about your experience?
Hey, good morning, everybody, or if you're on the East Coast, I guess it's good afternoon at this point in time. Glad to hear that many of the people we've worked with over the years are on this call today. Most of you know that at this point in time, I have over 40 years working with VA. Started with the VA really in the late 70s, and as most of you know, I started out as a social worker. That was my first master's degree in social services administration, and pretty early in my career I went back to graduate school and got a master's degree in healthcare management. And as some would see it, kind of went over to the dark side at that point, went into the old AD training program and had various assignments, and then was a medical center director at 3 facilities and ended my career as a vision director. And what you're going to hear from me today is really not any one theory of strategic planning, but sort of an amalgam of what I've learned in my 40-some years now of experience, both through formal exposure to strategic planning models, but also to my own experience in applying them as a director and vision director, and then in recent years as a consultant.
And Tim, just a question on that, looking back, having all that time in the organization as a senior leader, but now having spent about 7 years in that consulting role, how does it different? What's been different for you to be able to step outside and look at it from the consulting perspective versus, when you're sitting in that leadership chair in the organization and making those decisions?
A humorous answer to that, I'll quote Joe Dalpiez when we worked with him years ago when he was director in Philadelphia. And he said, Shea, you're like a grandparent. You can come and visit the kids, and you go home, and somebody else has to actually take care of them day in and day out. But I think, more seriously speaking and answering that, when you're in a senior leadership role with VA, you have constant day-to-day pressures that tend to occupy your time and tend to really cause you to take the eye off the ball at where you want to go strategically and tactically. As we all often say to directors that we work with, you guys have day jobs. As a consultant, we're able to come in and look at the organization with fresh eyes. We're able to focus totally on the planning aspect of the organization, bring to bear not only our experience, but the best practices from other VA clients we've worked with. So they are 2 very, very different roles. One could say as a consultant when we're coming in, assisting with planning, we're really fulfilling one of the functions that a director or senior leader has, but we're doing it in a more focused way.
All right, that's a great way to put it, Tim. And then, of course, just having my own experience, being able to work through this process with different sites provides a tremendous amount of perspective in terms of how best practices can unfold at 2 sites that may look very different. And that's something we're going to talk about as we get further into the presentation. So for myself, Seth Sinclair here, President and COO of Plan for Healthcare. Been working with VA for a long time, going back to probably more than 12 years. And that work includes projects with VACO, program offices, work in BBA. And then I've had the tremendous privilege of being on site with many different VA hospitals. So I've really seen a huge spectrum across all the different types of facilities out there, different geography, different size, different complexity. And that's been very beneficial in terms of understanding and learning more about the system. And I'll just throw out a note here that it was when Tim and I connected together back in 2010, which was when we really started to put the framework around this model and some of the best practices that we're going to talk about today. So, all right, well, that was just wanted to introduce this and get this kicked off for everybody. And so let's jump into some of the content. And so when we talk about this idea of planning and implementation and how this all comes together, I know, from my experience in a couple different industries to include the corporate side of the world and working as a leadership coach and trainer, that what you're going to generally see in most organizations is going to be some kind of a enduring mission statement or vision, really a vision statement that paints a picture of what future success would be like, a mission statement that follows that, which is going to be a little bit more action oriented. And then those are then drive down into goals that are defined. And I think probably most folks on the call are very familiar with the idea of SMART goals at the organizational level. So those are going to be time boxed. They're going to be designed to be achievable and measurable. And then they get further decomposed down all the way to the division level or sub-organization level. And that's where you begin to see specific, even more short-term strategies, tactics, and then measurements unfold. And then hopefully there's a way for all of that to be integrated together so that there's a way of looking at progress and measuring as things move forward. So Tim, when we look at VHA being a huge and complex organization, can you help us break that down starting at the core foundations of planning?
Yeah, I'll sure try, Seth. Many of you who we've worked with, and those of you we haven't, may be familiar with a planning pyramid slide that we tend to use during some of our opening training. And I want to talk about what goes into that pyramid. But before I do, just point out a key word, a key concept that when you look at that planning pyramid, and that is alignment. As we talk about planning throughout this session this morning, keep in mind that the real importance here is being able to align all the way down that pyramid between mission all the way down to operationalizing things at the service level, so that things really connect, if you will, in terms of mission, strategy, and then how it's being operationalized. So let's talk about this concept of foundation for a minute. And it all starts with the mission statement. And when we work with VA facilities, we don't spend a lot of time on this. Why? Well, the mission's pretty straightforward. We're all used to seeing the quote from Abraham Lincoln, "To care for him who bore the battle and is widow and orphan." Some of you have heard me talk about, in relation to the VA's mission, a true story that I was privy to, where a young Marine rescued another Marine in the jungle in Vietnam, and just before he died, he whispered, "I knew you wouldn't forget me." And I talk about, part of our mission as an organization is to show veterans we didn't forget their service to our country, and so therefore our mission is to really pay that back with the provision of world-class health care at the time and place they need it. So mission's pretty set. Now, what you'll see oftentimes, and I'm sure some of you have experienced this, is you'll bring in consultants, either external or sometimes internally from the VA, and they'll do an off-site event where they may spend a half a day or even more looking at developing a mission statement. Well, that's all fine and good, but to me, that mission's constant. It's there. We all know what it is and what we're striving for. The other part of that foundation, though, has to do with what are the key drivers underneath that mission that really drive planning, that should be what all of the planning aligns with. And in respect to that, you see, if you look back, every secretary, certainly in my career, since the organization became an agency in '89, and administrators before that had some key drivers. Most recently, Dr. Shulkin had the 5 pillars. So sometimes you hear the term pillars, sometimes driver, sometimes foundational pillars, but they all are kind of the same. And what we have adopted in our model is the 6 key drivers that many of you have seen that we've worked with, that crosswalk when you begin to compare it with just about every secretary's drivers, pillars, the thing that they build the VA's planning foundation around. Those are technical quality. That has to do, as we know, with the clinical outcomes, or for admin sorts of products VHA produces, really the quality of things like the buildings we build, the construction we do, the supplies that we bring online, that sort of thing. Second key driver in our model is the whole concept of access. And that access involves 2 dimensions. The first dimension is time, getting the veteran his care when he needs it and when he wants it. And the second dimension is geography, getting as close as possible to where the veteran is in order to provide that care. You can also operationalize the definition of that key driver for admin services, getting the products to their customers, usually the internal VA clinical staff, in a timely manner and in a place where they need it. Third key driver is what we term patient-centered slash care slash employer of choice, slash customer service. And that has to do with really taking care of the instrumental requirements, if you will, that a veteran, a patient has around the quality of their health care. They define that much differently than a clinician would around the technical quality. They want to make sure they're treated with respect, dignity, etc. Fourth key driver is maximizing resources. That has to do with really healthcare value proposition, using the resources in a cost-efficient way, and then maximizing the resources that VHA overall and a facility brings into the organization. Number 5 is being an employer of choice, pretty obvious, being able to hire and retain the personnel we needed, the best and the brightest, as I like to put it, to really run the organization. And then finally, the whole concept of building healthy communities and community collaboration. That's partnerships with affiliates, with VSOs, with other providers in the healthcare community, and all the people that really are part of the interaction externally for the organization. So the foundation really consists of that mission statement and those key drivers.
And Tim, would you say, I mean, over those last decades, that even though the emphasis on one key driver versus another may shift a little bit, that generally speaking, those are the non-negotiable elements that must be addressed, and that when you move toward developing a strategy at the corporate level, that's about starting to talk to the how that they're going to work on those key drivers?
Yeah, absolutely. When we consider the 6 key drivers I just went over, we always tell people technical quality is first and foremost. You want the good clinical outcomes. You want to do things in relation to patient safety and the outcomes you get. So that's always, the first, and is always eminent no matter what secretary or administration you look at. Access changed over the years. Maximizing resources and that value proposition has always been there. So while they may wordsmith it a little differently, we found that really over the past 40 years at least, those have been pretty consistent key drivers.
Okay, so then the next challenge is at that corporate level to start to develop the organizational strategy. So what does that usually look like?
So let's talk about that for a minute. Let's go back to that image of a planning pyramid. You've got the mission at the top, you've got the key drivers up there. Well, what occurs next is really the development of strategy and sort of those general overarching strategic goals. Where do those come from? Well, they come, from the secretary, from the undersecretary, and from VA central office, if you will. So, it's not like you would see in the corporate sector, healthcare or otherwise. A good example is, Tyson Foods. If you are managing a plant in Arkansas for Tyson Foods, your mission is the same as the plant manager in Georgia or the plant manager in North Carolina. You want to make a product where you're putting out, processed chickens to distribute to supermarkets that meet safety requirements. They meet requirements of taste and otherwise, and that's not going to vary a lot. Well, it's not a lot different, although the product is obviously much different. If you're a director at a VA facility or you're a vision director, your strategy is set. When the secretary says we will meet access standards and those standards are X, Y, and Z, you're not going to do something different. Your strategy is set. So once it gets handed from central office to the vision level, the vision may put those overall strategic goals in more measurable terms. And so those are going to be translated through the vision to the medical center level in terms of fairly measurable sorts of strategic goals that a facility is going to need to meet. Oftentimes they're very explicit and very clear coming out of the vision. Sometimes they're not, but they certainly can be interpreted through a director's contract. So at that point, the strategy is there, the strategic goals are there, and a facility then needs to look at how we begin to implement that strategy.
So Tim, when we start to talk about time horizons for these different types of planning elements, how can we characterize those at each of these levels?
Well, you know, those of you who are familiar with strategic planning literature know that we used to talk in terms of about 5 years for a strategic horizon and setting strategic goals around 5 years or so. I think more recently, that's probably more like 3 years. And so, you know, for a lot of reasons in healthcare and industry overall, a 3-year planning horizon in terms of strategic goals is really what we're looking at.
Okay, and then when you get down to the detail, really that operational facility level, oftentimes you're only going to be looking out maybe 1 or max 2 fiscal years. Would you agree with that?
Yeah, I mean, I think the 3 years strategically still holds, but why don't we talk a little bit about operationalizing that strategy at the facility level, at the medical center level, and then we can talk a little bit about that timeline.
Absolutely. So when we talk about this overall planning, now we're drilling down to that next level at the medical center, where you're dealing with the leadership team locally, and we know from our observation that there are challenges that they face in order to perform strategic, effective strategic planning. So can you talk about a few of those?
Sure, and certainly none of these things I'm going to talk about are foreign to those of you on the call, but probably the first challenge that I have found over time when that strategy gets handed down to the medical center level is sometimes there is a lack of clarity. And, you know, depending on the vision, it may or may not be clear what are my strategic goals that I have over this next year, 3-year planning horizon. You know, how do I measure them? What is it that's expected of me? Oftentimes, the political environment can be a challenge, and that's differential across facilities. How many times, as a director, have you all experienced, you know, having a local congressional member challenge you or almost mandate that you establish a CBOC in a certain place? So there's a lot of politics that come into play when you begin to operationalize the strategic goals at a medical center level. There's oftentimes shifting priorities at the corporate or the VACO level. You know, that's probably something that applies very much right now. You know, recently the secretary resigned. There is an acting secretary in place, and while some of the priorities are consistent, some of them have changed a little bit. Some of it changed, you know, since the new choice legislation and the whole emphasis on modernization. So priorities change, and it's always a challenge at the medical center level to try to predict where those are going. There's always uncertainty around funding and the budget. You know, there's some predictability with that, but the reality is that we're always dependent on what is the overall budget from Congress for VHA and how is that going to be distributed to you as a medical center, and how will that affect your reaching the strategic goals that have been set for you. There's also leadership turnover, and that's at all levels. We just talked about a secretary resigning. Oftentimes, vision directors come and go, and they may, the new vision director may set a different priority on strategic goals than the person that he or she replaced. And then there's also leadership turnover at the facility level. Directors come and go, ADs, chiefs of staff, others in the senior management ranks, and that can affect the really consistency over time in meeting strategic goals.
So Tim, so what we're painting a picture of here is it is definitely a difficult seat to occupy when on one hand you've been mandated certain things that you need to achieve. The degree of clarity on those may be variable. And then on the other hand, you're getting these other things thrown at you, which may include, again, local politics, demands there, other shifting local priorities. You may not know your total resources to work with. And then even if it's not the director experiencing the turnover, you may have other key ELT members who are in a state of transition, which does make it difficult to get a grip. So I think we all agree this can be a very challenging process to embark upon with any confidence as you go from year to year. There's even more challenges when you really start to drill down truly to the local level and the variables there. What are some of those assumptions that you're often trying to figure out as you work through it at that level?
Well, there's a lot of things, and I want to go back, if I could, to really the slide and the whole discussion around, sort of looking at that planning pyramid and getting down to where a facility operationalizes the strategic goals. Thinking in terms of, what we've said here. What your goals are strategically. Some are clearer than others, but using access again as an example, you have very clear goals as a medical center as to what you are to achieve from the standpoint of access around the timing of when services are provided to veterans. How do you operationalize that? Well, that becomes a very tactical thing. And so that should be set really in terms of a tactical initiative that may be across that 3 years, but then you operationalize it with a certain objective moving towards meeting that goal over that 3-year planning horizon. So, for example, if the strategic goal or objective or initiative for a medical center is to meet access standards 100% of the time by 2022, they begin to operationalize that so that in fiscal year 2019, they may be trying to achieve 90% compliance with standards. And then they would set in that plan very specific actions with timelines that they would move towards to meeting that objective, so that by at the end of 3 years, they're up to 100%. So once again, looking at the pyramid, we started with the mission, we've got the key drivers, we have the strategy that's set by central office, we have the goals coming from central office and from the vision level, and at the medical center level, we're looking at how does that play out in terms of very tactical initiatives over a 3-year horizon, and then very specific tactical objectives each year. Now, getting back to your question about at the local level, what are some of the factors that come into play? Some that come to mind to me, first of all, are things like some market factors. We may see a facility that can easily recruit healthcare providers, can easily recruit nursing staff, other support staff, versus a facility that can't. And so there's a real difference in the ability to hire and retain. How does that come into play when we're using an initiative, a tactical initiative for something like timeliness and access? Well, fortunately, we've got two people that I think represent both ends of the spectrum on today. We've got Kathy Berger, director in Montana, who's in a very rural area, has a huge area to cover, and it's an area where the availability of healthcare providers in general is fairly scarce. It's not easy to recruit someone in rural areas of Montana to provide healthcare services. On the other hand, we've got Tom Wisniewski on, who comes from the North Florida, South Georgia system that comes from a large but very densely populated area, and an area where it is fairly easy to recruit the best and the brightest when it comes to healthcare providers, when it comes to nursing staff and so forth. And in addition to just the nature of the geographic area, they have an affiliation and other things that lends itself to that recruitment that Kathy doesn't have in Montana. So when you see a tactical initiative for Montana related to timeliness of access over time, it may include something that really deals with provider agreements and contracts for care with providers in various areas of the state that they serve, because they're not able to recruit the providers themselves. Tom, on the other hand, when he is setting an objective for North Florida, South Georgia, is probably more likely to have an objective that relates to establishing, various CBOCs, maybe establishing, various specialties where he is going to provide, that his system is going to provide that care themselves. So, there's a lot of differentiation in that respect in the local area. There's also a difference, as we know, in terms of the physical plant and infrastructure of many VAs. Space seems to be at a premium based on my experience just about wherever we go, and that includes brand new facilities, believe it or not. So, that differentiates, between facilities. Some facilities may be able to hire providers, they don't have the space. So the objective becomes a different one. So there's a lot of unique things. Think of the old saying, you've seen one VA, you've seen one VA. So how those strategies, those strategic goals are played out at the local level in terms of their tactical initiatives vary a lot by local conditions.
Tim, I know a lot of times when we work with sites, just to follow on with what you said, they'll tell you that they have unique needs in their patient population, that, their patients are sicker, or, there's certain conditions that are more present for them than maybe at other sites. And just curious that, I think sometimes we've seen evidence of that and sometimes we haven't. What's your take on that?
There's probably some variation at a lot of sites when you compare one to the other. Probably most sites are the same. They're dealing with an older Medicare type population for the most part, although, there's more and more veterans that are coming from Iraq, Afghanistan, that are younger coming into the system. However, there are some unique variables people deal with. It's very different dealing with a patient population from inner city Philadelphia than it is from the rural parts of New Mexico, for example. There are certain demographic and ethnic variables that affect healthcare. I know from my time working with veterans in the lower Rio Grande Valley, there were much different needs than when I was working in Little Rock, Arkansas, for example. So things do vary, and certainly there are unique needs that have to be looked at depending on the particular facility.
Okay, so really to summarize, I think what we wanted to get at here is the idea that same organization, same mission, same key drivers, and yet depending on that local facility or even the region and then down to that local level, you may see two completely different approaches to trying to achieve that same strategy and all the different variables that are going to affect that. That's a nice segue, though, into the data aspect of this. And I want to talk about this just for a second because data is a critical part of planning at that local level as a site tries to discern what are their specific opportunities within the broader strategic umbrella that they're trying to achieve. They're going to need data to figure out what are those specific opportunities and challenges for them that are most important. And yet, while VA has a ton of data, almost inundated with data, which is of high value and probably exceeds the data that many healthcare systems have available to them, it also becomes a challenge to know how to sort through that and what data to trust. So Tim, from your perspective, what does it look like to use data effectively, and what are some of the things that may make it difficult at the local level to really embrace the data and feature it as part of the planning process?
Well, there's a number of variables, Seth, that I've seen over the years. Probably first and foremost is surprisingly for the second largest organization in government, and a multi-billion dollar organization. Many times at the medical center level, they lack individuals who are adept and have the skills to go into the various databases, pull the data, and then oftentimes lack people who are able to analyze that data. So surprisingly, that's one of the challenges I've seen over the years. Another problem I think that I've often seen with data at the medical center level is really the quality of the data. It's the old garbage in, garbage out phenomenon, in that the data entry may be inaccurate. Data capture in terms of the entry of workload and other aspects of data may not be occurring at the level it should. And that sometimes leads to service chiefs and senior managers not really trusting the data. And then oftentimes we'll find that various databases, when you pull the data, will conflict with one another. And that has to do a lot with the parameters that are set in pulling the data and other variables. But surprisingly, for an organization as rich in data as the VA is, there really isn't the systemic sort of process and structure in place to always pull that data and analyze it in a way that's useful.
And I think one of the other things that's related to what you said that we've observed is there may be some mistrust due to the data input, but also you've got managers in the organization who will tell you a very different story from a boots on the ground perspective, day-to-day operations about, what are the challenges, what are the opportunities in the organization, and it doesn't really jive very well with what the data says. And so, from your observation, how do you work past that?
That's sort of the $64,000 question, if you will. Unfortunately, I think overall, senior managers in VA are not always good at really forming data-based opinions and looking at designing their tactical initiatives and objectives based on the data. It's really important that an organization really become one where the culture is such that they make decisions based on data, and knowing what the most important data is to look at the senior management level.
And would you say that this is something interesting that we've also observed is a lot of the reports and measurements that at the local level that the leaders are looking at are ones that are going to encourage them to almost be more reactive to the data in terms of, a problem has popped up, versus looking at other sets of data which may be more proactively focused in terms of what to expect in the future. Can you just talk a minute about how, those two different data sets can be useful to the leaders so that they're not only looking in one direction?
Yeah, absolutely. It's probably helpful to talk about what are the most important data elements that a senior manager should be looking at. And I'll be speaking to the choir with this a little bit because I know many of the folks on this call have been clients of ours, and they've seen our strategic analysis process, which sort of, really just structurally lends itself to what I'm about to say. the first and foremost thing I would look at as a senior manager is to look at the demographic and workload projections. Those are available through Milliman. You are able to look at that and see over time, particularly for this 3-year planning horizon we're talking about, what the trends are in terms of your veteran population. You're able to look at what the workload trends are going to be, both for ambulatory services and specialties, but also bed levels. How many beds do we need over the next 3 years? And, able to really ascertain that from that Milliman sorts of data. The other thing to look at, I think that's very important, is the workload trends. You have the Milliman projections, but what have we actually accomplished in terms of workload and types of workload over the last 2 to 3 years? And, are we trending where Milliman says we ought to be trending? Related to that is, really the financial side of that. Are we maximizing FAC work and the complexity workload we need in order to not only maintain where we're at in terms of our Vera funding levels, but actually increase it and maximize it as time goes on? And then, of course, there's the obvious things that you need to look at for survival these days, and it gets back to the technical quality driver. You want to be looking at the Spark data. Are we meeting access, and are we meeting technical quality, safety sorts of measures that go into Spark? So to me, those are probably the key things I would want to know, really through a dashboard, if you will, that I'm able to regularly look at as a senior manager.
And Tim, when you mentioned Spark, that's obviously productivity focused, where SAIL is the big, looking holistically across some of those other measures that you mentioned.
Yeah.
So I think I know the language that you and I would use is the challenge really is to be able to connect dots across all of these different data elements and to strike that appropriate balance of what are the things out there for that particular organization in that market that they want to tune themselves toward looking forward, and then what are some of the internal opportunities related to current performance, efficiency, cost management, and quality. And those things really all need to be pulled together into one place so they can all be managed in an integrated way.
Absolutely. That whole concept of connecting the dots is critical for senior managers to really implement. So let me give you an example of that. If you're looking at your Milliman data and it is indicating that beginning in 2015, over the 5 years, as we're looking at now, the 3-year planning horizon from here, between 15 and let's say 2021, your workload is trending up on an ambulatory basis and projected to go up about 50%, and yet you're not seeing that. When you connect that and correlate that with your actual workload, that's a red flag. It means we need to look at what's happening with that, and should we be establishing tactical initiatives, 1-year tactical objectives that will address that. Another example could be from looking at Spark data that's showing specialty capacity and correlating that, connecting the dots with what we have going out for non-VA care and choice. It's not unheard of when you look at that data to see, we have capacity in GI, and yet we're sending a huge number of cases out under non-VA care or under choice. And really being able to do that analysis to say, why is that occurring? Is it for geographic reasons? Are we operating efficiently in the clinic? And then being able to address that through an objective.
All right, well, that's a perfect segue into that next slide that we had here, where we wanted to talk about, driving further down into the level of execution. Now, we've seen some sites that we've worked with that actually have done a good job of asserting what their strategic level priorities are for that 1 to 3 year time horizon. But then you sit back and watch them struggle to really truly execute. And by execute, I also mean, not just having a team that's looking at one certain area, but really changing the way the organization operates on a day-to-day basis so that there is more alignment with, where they're trying to lead the organization. So how does a leader at that local level start to truly push their priorities down into that department level operations?
That's probably the key variable of this whole thing. I want to go back to this image of this planning pyramid. Remember, we started at the top with a mission. We had the key drivers. We then had the VACO, strategic goals, strategic direction, that got pushed down to the vision. The vision had very strategic and specific goals for the medical center. The medical center then tactically looked at, how do we want to operationalize those over 3 years, and then how will we set objectives annually that move towards accomplishing that 3-year tactical initiative. And so we see sometimes, as you just pointed out, Seth, medical centers are good at getting to that point, but then you look at the end of the year, at the end of 3 years, and they haven't accomplished it. Well, why is that? It's not rocket science. It's sort of like, a football team where you have a great coach, you have a great plan, and the players just don't follow the playbook. And in the case of VHA, in a VHA facility, we haven't driven those initiatives down to the service level so that a service is looking specifically at what portion of that tactical initiative, what portion of that objective for this coming fiscal year do I own? How do I state that as a measurable objective with clear actions to get there? And then how do I align my resources at the service level in order to achieve it? So full alignment really requires that. Otherwise, you may have some great plans, great tactics in place, but you won't achieve them if they're not implemented down at the bottom where the services live.
So Tim, just to make this real, can you share an example of where an initiative began to drill down into that service level and how resources actually began to, shift to follow those priorities?
So I want to use as an example a facility we worked with in the past, large 1A, that was losing complex workload. Their FAC work had been trending down for about 3 years. So their overall objective over the 3-year planning period, their tactical initiative, was to increase FAC work by 20%. And so for the upcoming fiscal year that we were working with, they set as an objective that they would increase it by 5%. And so they then looked at one of the ways they were going to do that was to expand their HBPC teams. HBPC at that particular facility was under AD for patient care, under nursing service. And so nursing service literally set as in an initiative that within 3 years they would expand their HBPC teams to 3 additional CBOC sites and have 3 additional teams. So the objective the first fiscal year was to expand it by 1, second fiscal year by 2, and the third by 3. And so, that initiative at the facility level to increase the FAC work and then to have an objective that says they'll increase partially through expansion of HBPC and then nursing own that and drilled it down and asked for the resources each year to bring on board those HBPC teams was actualized and contributed to that facility's actually meeting the goal of their FAC work expansion.
That's great. Thank you for sharing that, because I think that does help start to bring this all together for the folks on who are trying to think about, how do I get this done in an effective way? Certainly, I promised in the beginning we weren't going to spend a lot of time talking about specific solutions, but this very ability to connect those dots down to the service level and create those types of plans and alignment is something that we wanted to achieve when we developed the forecast tool. So for the folks that are online that are using that, as well as this thing we call the SCORE methodology, which was our focus of trying to create more consistency in how these types of plans are developed and executed all the way down to the service level. So this is what we call it, and this is our best practice and our method for trying to standardize that. Tim, when you reflect back on your experience, again, wearing both hats, but maybe especially when you were a medical center director or a visiting director, what did consistency mean when it came to planning from site to site, or even within the region? And how can that be something that can be beneficial to the organization?
Well, consistency is extremely important. Everything we've talked about today is very practical. I think in terms of a very pragmatic sort of planning process that you can really see results from. It's nice to have this great strategic plan that sits on the shelf, but the reality is you have to implement it. You have to actually achieve some of these things. And when we designed the SCORE model, it was really meant to do that. And it creates consistency within an organization. But, I think even more importantly, when I look at my past experience when I wore the hat of a vision director, at that time, we didn't implement SCORE or a model like this across the vision. And I had different facilities in my vision that, were doing their planning in different ways. And we were getting varying results for that. So consistency is important across the vision. It's important in a medical center, and that, you want to have a consistent model. You want to build that into the culture, and you want to be able to standardize that methodology year in, year out. And that's how you begin to get results.
And so I think we would all agree that even if you're not going to use, sites not using our particular methodology and tool set, that it really does benefit them to find something that is consistent, understood by the staff. It has plenty of communication built into it, and then that ability to truly integrate planning at both levels so everything can be married up, measured, and really managed moving forward. And then again, something that safe proofs, if you will, safeguards that organization's plan against some of those variables that we talked about before, such as leadership turnover, so that plan endures, beyond just one specific person who's doing the heavy lifting to, do all the detailed planning and then, try to track everything together.
Yeah, absolutely, Seth. I just want to follow up on one thing you alluded to, and that's being able to have these so that they're very clear and understood by all levels of your organization, all levels of the facility in the medical center. One of the things in my career, probably the thing I'm most proud of is when I took over the South Texas system. We were, years and years ago when we were still under the old performance measure system where they literally ranked facilities from 1 to 143. The year I took over, we were at 136. And we developed a very clear planning methodology with very clear objectives. And within 2 years, we went from 136 to number 3 in terms of the rankings across the system. But what I was most proud of is we had a joint commission survey during that time. And the joint commission surveyor said, I have never seen anywhere before when we asked a housekeeping employee what the strategy of the organization was, he not only was able to verbalize that in general terms, he told us what your primary objectives were. Primary tactical objectives were to accomplish this fiscal year. And when you can do that, it takes planning and it changes the culture so that everyone within the organization, from your most sophisticated subspecialty provider to your housekeeping people, know where you're going and where you want to be.
Tim, that does remind me of some of you guys may be familiar with the author Patrick Lencioni. He's more famous for the 5 dysfunctions of teams, but he also wrote a book called The Advantage. And in that, He has multiple stages in terms of planning and execution focused on communication. He basically asserts there is no such thing as over communication, that, in order to drill down to every level of the organization what the priorities are and have people thinking about what does it really mean for them. And that's a good, we're only have a few minutes left, and we did promise we'd wrap up on time. Right here, we just have a snapshot of a site that we worked with over several years. Certainly, this is in this particular case, this is a challenging site, and not everything's perfect, but there certainly have been some measurable gains as they've implemented a standardized planning methodology and started to put tools in place. You want to just take 1 minute to talk about some of the outcomes at this particular site we've worked with?
Sure, and I'll do it quickly. But this is a huge medical center. We're not going to tell you the name, but it's one of the biggest in the system. When we first started working with them, they literally didn't know who owned FTE within the organization. Their mapping was terrible. They literally couldn't say this service has X FTE, this service has Y FTE. They were all just out of whack in terms of their fiscal control points, no discipline whatsoever in terms of how they were budgeting. And from a planning perspective, it was just sort of let's try to survive every year. They were a star one the first year we began working with them. Over the course of the 3 years we worked with them, and probably most significantly that first year, they were projecting a $25 million deficit. And even though their budget was close to $1 billion, obviously the vision wasn't happy that they were going to have to bail them out again because that was an annual process. To make a long story short, really applying our model over the past 3 years, they achieved at the end of the second year a balanced budget. They're very clear on how their FTE are organized and aligned. They now have a governing structure in place that's able to deal with assignment of resources. Their control points are being allocated appropriately, managed appropriately, and they're staying within budget. And most significantly, they went from a 1-star to a 3-star sale rating, which is kind of interesting. What I find in working with facilities is usually facilities that are sort of out of whack and running deficits and having budgetary issues aren't performing well clinically either. And so when you begin to apply these planning techniques to the organization, not only do the administrative and fiscal things improve, but usually the clinical stuff does too.
That's a great point, Tim. Well, let me stop. We only have a very few minutes left, but seeing that we have folks on the line, again, who have worked with us and who have a diversity of experience, we did want to open it up. You guys can use the chat to raise your hand, and I can unmute anybody who might like to say something. Were there any questions or comments anybody wanted to share before we close things up? All right. Well, go ahead. If you're working with the controls here and you'd like to try to ask a question, go ahead and do that, and I'll be mindful of that here in the next minute or two as we summarize. What I'd just like to say is, again, we hope there was something in here that you found helpful related to thinking about some of the challenges with regard to planning, how these pieces can begin to come together at the local level and drive results, and some of the really positive outcomes when it comes to having consistent methods and tools for tackling this challenge, and giving the leadership team at the local level some framework through which they can actually work on these things. I think looking forward, we're going to do other webinars, very related topics. We can do a part 2 on this with more specific examples. I do want to go back to the data piece and mention that we will almost certainly have one focused on all those different data elements and to drive down into them and how to further interpret them, and where even to look at those. And we'll bring our healthcare economist on the team for that. So Tim, before we wrap up, let me just thank you for being on here today and sharing your thoughts and experience. Do you have any closing comments for the group?
No, I hope that it was clear. It's always difficult to describe a planning process, but I would go back to what I sort of started out with. This is a very pragmatic approach, and the real importance here is to get the actual results and implementation at the facility level.
All right, well, thank you, Tim. And contact information is up here. Certainly, I believe through the webinar links, there's ability to contact us and follow up. Any questions on this, any feedback, any requests for additional topics that you'd like us to tackle, we'd be happy to field those. Otherwise, thank you all very much for your time. We'll provide links to the recording, and we'll be in touch when we set up our next session. So thank you all, and certainly appreciate it, and best wishes with your day-to-day planning and operations and strategic planning moving forward.